Thank you very much. Good morning, everyone. First of all, I must thank organizing committee of Sri Lanka Medical Association for inviting me to do this presentation. Topic of my presentation today is leptospirosis, bad to worse, a change of clinical pattern. Let's start with an introduction. Leptospirosis is the most widespread zoonosis. It presents all over the world except Antarctica. It has become an emerging and re-emerging disease in most parts of the world. Annually, it infects more than 1 million people in the world and is responsible for about 60,000 deaths. Leptospirosis is very much underreported, as we all know, not only in Sri Lanka, many parts of the world it is being well underreported, and the actual disease burden could be much higher than the estimated because of this. Leptospirosis is in the group of 17 neglected tropical diseases categorized by WHO. South Asia is reported as highly endemic region for leptospirosis. What about the Sri Lanka scenario? Sri Lanka is a hotspot in the world. Now, why do I say that? Because in this is the map of world map of leptospirosis, where Sri Lanka is in red. Red in this map indicates that there is over 100 estimated annual morbidity due to leptospirosis cases per 100,000 population. Over 100 cases per 100,000 population is a very high figure. Even in highly endemic regions in the world, Sri Lanka is one of the highly endemic country. Now, to discuss something more about leptospirosis, I would like to present you a case scenario. Actually, this case was published by Dr. Senaka Pilipiti and his group, and with his kind permission, I am going to discuss this case with you today. It is a 31-year-old pregnant woman who was in 12th week of gestation, was transferred from a local hospital to teaching hospital Anuradhapura with a history of vomiting for 10 days and dry cough for 5 days. And on the day of admission, she has become quite suddenly short of breath, and she has produced hemoptysis. So that was the reason why she ended up in the hospital on the day of admission. And she was initially admitted to observe and then referred to medical unit for further assessment on the following day, since the patient was predominantly having a medical issue. At the time of admission to medical unit, she did not have jaundice, myalgia or abdominal pain, or she has not given a history suggestive of reduced urine output. The examination revealed she had rapid heart rate, tachycardia. She was having severe tachycardia of 140, and blood pressure was low, 90/60, and she was quite tachypneic, and her respiratory rate was 42, which was she was very tachypneic, and her peripheral saturation was quite low. It was 80%, and the patient was conscious but restless due to severe shortness of breath. And there were crepitations in the middle and lower zones of both lungs, and rest of the examination was no. Investigations, she has had high CRP of 258, and her full blood count was predominantly neutrophilic, and platelet was low, 127, and she had high bilirubin, and the dominant abnormality was seen in arterial blood gas, where she has had severe arterial hypoxia. PaO2 is 45, and her saturation was 76 while she was on FiO2, while she was breathing 40% of oxygen. So PNF ratio was 112, indicating that she was in severe acute respiratory distress syndrome. The clotting profile was mildly elevated, and apart from that, the following investigations: serum creatinine, transaminases, serum electrolytes, blood picture. There was no evidence of hemolysis in the blood picture, and blood and urine culture all were negative, and all these investigations were essentially normal. And she ultrasound scan showed single live fetus, and ECG and the 2D echocardiogram were normal. The summary of management during her hospital stay: she was initially managed as a case of atypical pneumonia with IV antibiotics. She needed high flow oxygen via face mask, but later on it was not adequate and needed continuous positive airway pressure. And since her oxygen requirement was increasing and her general condition was deteriorating, she was transferred to medical ICU where she suffered a miscarriage. And her oxygen saturation further dropped to 54% while she was in the MICU, and she underwent intubation and put her on mechanical ventilation. While she was in the ICU, she had maximum supportive care, including inotropes and blood products. But unfortunately, she developed bleeding from the endotracheal tube, and subsequently, she dropped her blood pressure to 80/50 despite inotropes. Later, unfortunately, she had a cardiac arrest and died. This happens within few days after admission to hospital. So autopsy was done, and autopsy revealed blackish red, heavy and edematous lungs in the external appearance. And in cut section, it showed multiple large areas of hemorrhages in the lung parenchyma with edematous congested lung tissues. And meanwhile, the serum leptospira microscopic and agglutination test, which is the diagnostic test done at MRI to confirm the diagnosis of leptospirosis, became positive. And the cause of death was leptospirosis associated pulmonary hemorrhage. What is the significance of this case? Now, we all know that this patient is not a candidate from high risk groups. She is not involved with any agricultural work, or she is not in a high risk of exposing to contaminated water. Because of that, nobody would suspect leptospirosis in this patient when she come to obs ward with an acute febrile illness. So, apart from that, the minimal or no evidence of traditional organ involvement, which is common in leptospirosis. For example, renal, liver and hematological involvement were minimal or no. And also, she had a very rapid deterioration despite maximum organ support. All these features or facts are important because that's why this case is important to discuss, and that is the importance of this case. According to traditional classification of leptospirosis, you all know that the 90% of leptospirosis cases are mild. Mild form means mild is symptomatic, so no symptoms at all. They are usually anictoric. They consider to be anictoric, and if the patient is anictoric, people thought that it's a milder form of leptospirosis. Whereas if the patient was icteric, people consider it as a severe form of leptospirosis, or it was called Wales syndrome when it was associated with this classic triad: jaundice, renal impairment, and bleeding diastasis. But this is, if you follow this traditional classification, you will be in trouble, because what we observed and what is reported in all over the world is different. Often, the clinical picture of leptospirosis depends on the organ that are involved. the predominant organ, if the predominant organ involved is kidney, the patient will be having renal related symptoms. So same with hepatic involvement. If the patient is having pulmonary involvement, or the lungs are the major organ which is involved in this infection, so the patient will be having respiratory symptoms rather than traditional symptoms like oliguria or icterus. So patients with severe leptospirosis may or may not have icterus or jaundice. In other words, the icterus is not synonymous with severe leptospirosis anymore. The other thing that I want to highlight is that no system or organs in the body is immune to leptospirosis. So, however, high mortality has been reported and associated with when there is a pulmonary involvement. When there is a pulmonary involvement in leptospirosis, the mortality goes up to 70%. This is well documented mortality rate found in the literature. It's more than 70% of mortality when there is a pulmonary involvement. The mortality can further go up if there is a concomitant renal and cardiac involvement. LPH or leptospirosis induced pulmonary hemorrhage can be very severe. These are some of the pictures of some of the patients whom we have managed at Teaching Hospital Karapati. There is a young man who came with evidence of pulmonary hemorrhage, and X-ray showed severe, extensive involvement of both lungs, and he was lucky to survive. And this is another case, a young man again coming with evidence of pulmonary hemorrhage, and he produced lot of hemoptysis and went into respiratory arrest in the ward. So we had to intubate him in the ward, and when we intubated, we noticed that gush of blood coming through the ET tube even into the ambu bag. So this was a picture of a post-mortem finding of a patient who was not so successful to survive. I mean, was not lucky to survive and ended up succumb to his condition. And this is a cut section of his lung showing extensive hemorrhage. What is this condition? What is leptospirosis-induced pulmonary hemorrhage? Now, first, it was described in 1995 in Nicaragua with an outbreak that happened in 1995 in Nicaragua. There, the researchers found or noticed that a cohort of patients who died of confirmed leptospirosis, whose cause of death was not the traditional causes like liver failure or renal failure, it was due to severe pulmonary hemorrhage. There, the renal and hepatic complications were minimal. Later on, many other countries also reported the same condition. Later, they named it as this condition as severe pulmonary hemorrhagic syndrome. In Brazil, going back to their surveillance data, they found that this is an entirely new phenomenon. They published a paper in 2008, and they concluded that it's a change of clinical pattern of leptospirosis in the recent past. What Sri Lankan scenario? Way back in 1977, a well-documented case series of 7 cases of pulmonary hemorrhage in leptospirosis has been reported from T.H. Ragama by our late well-known physician and a great teacher, Dr. Ramachandran, published this case series. And that was 1977, long before it was described by in Nicaragua. So it's an important publication as far as Sri Lanka is concerned, at least. And in 2008, from Teaching Hospital Karapita, another autopsy series was reported by JMO, where they have reported in 2008 there had been 459 cases of leptospirosis. Out of that, there had been 25 mortality. Out of the 25 mortalities, autopsy was performed in 21 cases. The cause of death of all these 21 cases of autopsy was due to pulmonary hemorrhage, severe pulmonary hemorrhage. In 2008, again, Teaching Hospital Peradeniya reported 30 deaths due to pulmonary hemorrhage. And in 2019, from Teaching Hospital Karapitiya, we reported more than 100 confirmed cases of pulmonary hemorrhage. So this concludes that leptospirosis associated pulmonary hemorrhage is a well-established clinical entity in Sri Lanka. So moving on to the pathophysiology of pulmonary hemorrhage, this is a normal alveolus in a cartoon form of diagram, and this is the same thing in a more histological sort of descriptive diagram. And you can see this light greenish tapering thing is a cell which is called type 1 pneumocyte, which covers the more than 95% of the surface of the interior of the epithelium, alveolar epithelium in the lung. So it's closely situated in proximity with the alveolar capillaries. So it forms the alveolar capillary membrane, the type 1 pneumocytes, and the epithelium of the capillary alveolar capillary form the alveolar capillary membrane, which is the most important structure as far as gas exchange is concerned. What happens in leptospirosis pulmonary hemorrhage is there is a linear deposition on immunoglobulins and complements on the alveolar surface of the epithelium, which causes direct damage to this most important alveolar capillary membrane. There the result is this with as immunocomplements deposition occurs, it damages the alveolar capillary membrane and results in hemorrhage into alveolar space leading into alveolar hemorrhage. Some of the other important facts about pathophysiology of leptospirosis associated pulmonary hemorrhage. Thrombocytopenia or significant coagulopathy is not the primary cause of hemorrhage, which has been confirmed and repeatedly documented in the literature that thrombocytopenia or significant coagulopathy is not the primary cause of hemorrhage. And also, there is no evidence of associated vasculitis. There is no underlying immune process going on in these patients to produce pulmonary hemorrhage. It was actually due to an acute non-inflammatory lung injury that affects the alveolar capillary membrane, where it results in enhancement of permeability of type 1 pneumocytes and capillary epithelial cells, and which impairs the alveolar fluid clearance. Because of that, there will be a fluid collection in the alveolus leading into pulmonary edema. When the capillary epithelium get damaged, it leads to alveolar hemorrhage. So both these conditions, causes, pulmonary edema and alveolar hemorrhage, ultimately leads to respiratory failure. Little bit about immunology, and as you know, severe leptospirosis consists 10% of cases. The severity of the infection may depend on the virulence factors of some of the pathogenic strains which cause this condition. But the evidence to support this is not that robust. The major contributing factor which determines the severity of the infection or the pulmonary hemorrhage is the immune response of the host, which is the main contributing factor. And in mild case, what happens is the immune response is well regulated and is quite enough, it's fine-tuned and controls infection quite easily and early. Because of that, the mild cases of the patients with mild leptospirosis will not develop severe complications. But as compared to in severe cases, what happens is there will be a overreaction of immune system which goes out of control, and which is called dysregulated immune reaction, leading into cytokine storm and immune paralysis, and which ends up in sepsis and multi-organ failure. So, but this occurs in a genetically susceptible individual. So, we can conclude that ultimately the severity of leptospirosis is a thing which is determined mostly by the genetical factors. The clinical features. The clinical features depend on, as I told you before, whether the pulmonary hemorrhage is a result of classical leptospirosis, or we call Wales syndrome, where hepatic, renal, and hematological manifestation would be dominant. So the patient will have jaundice and oliguria. But the problem arises if the pulmonary hemorrhage is due to severe pulmonary hemorrhagic syndrome, where there is a minimal organ involvement. The renal and hepatic involvement is minimal. Because of that, the traditional symptoms of leptospirosis won't be there. So the predominant symptomatology of these patients includes respiratory related symptoms. Tachypnea is one of the earliest features of pulmonary involvement, which is very characteristic, and that happens quite early in the disease. And hypoxia, especially arterial hypoxia, follows, and which happens quite early in the disease. I mention arterial hypoxia especially because the peripheral hypoxia can occur, but it takes longer time to detect, manifest. But arterial hypoxia, if the facilities are available, if you do arterial blood gas, which will detect arterial hypoxia, which is a quite early finding in these patients. Now, hemoptysis is quite common, but not happen always, but it's quite common symptom. But again, it takes few days to develop. Hemoglobin drop is also a supportive evidence to support that the patient is having hemorrhage. And what is most important is the chest X-ray finding. Chest X-ray infiltrates, which is the commonest and most commonly used tool to diagnose this condition. Little bit more about imaging in leptospirosis, pulmonary hemorrhage. Chest X-ray will show small nodular opacities that may progress into larger coalescent areas of consolidation, which we call alveolar shadows or cotton wool shadows. A typical description of alveolar hemorrhage, and this usually bilateral and often inferior and peripheral, but in the early stage it would be focal and unilateral. If the facilities are available, the HRCT would confirm the same thing. How are you going to diagnose leptospirosis pulmonary hemorrhage? In a clinically suspected case of leptospirosis, what do you mean by clinically suspected case of leptospirosis? Is a person who is coming with acute febrile illness, complaints of myalgia and multiple body aches and pain, and a clear history of exposure, being exposed to contaminated water. So that we take as a suspected case of leptospirosis. If this suspected case of leptospirosis shows the signs of respiratory distress, that is tachypnea and hypoxia, and one of the following, say hemoptysis or chest X-ray infiltrates or significant hemoglobin drop. One of these things, together with above mentioned things, in a suspected case of leptospirosis, you can confidently diagnose leptospirosis associated pulmonary hemorrhage. So what is the treatment? In short, treatment of shock is very important, and often these patients come dehydrated, and use of IV fluids is very important, and there you have to be very careful that not to overload these patients, especially if you are suspecting pulmonary hemorrhage. You have to be very judicious in using IV fluids, but it is an important part of management. Inotropes also can be used to maintain adequate blood pressure, and early use of antibiotic is indicated, and it should be done. It should be, if you are dealing with the pulmonary hemorrhage, it should be IV antibiotics such as cephtriaxone or IV penicillin. Try to keep platelet count above 50,000 by platelet transfusion. And the mainstay of treatment of leptospirosis pulmonary hemorrhage is immune modulation therapy. There you can use steroids, therapeutic plasma exchange, and IV immunoglobulin, which is not frequently available all over the country. Little bit more about the steroids in pulmonary hemorrhage. IV methylprednisolone has been shown to be effective in severe cases of leptospirosis. And so many occasions in the recent past, it has been shown to be effective. In 2010, study done at Peradeniya by Dr. Kularatna and his team showed that the IV methylprednisolone had been 500 milligram for 3 days, daily for 3 days, followed by 8 milligram for 5 days, is quite effective in moderate to severe leptospirosis. It was also demonstrated that it was more effective against pulmonary hemorrhage. However, the negative side of this is it was not effective, or the efficacy was reduced when there is a multi-organ involvement, and also it was complicated with sepsis when the patient needing ICU care. Therapeutic plasma exchange was the next option for us at Teaching Hospital Karapiti when we observed high mortality due to pulmonary hemorrhage in 2017. So we did little bit of reading, and we found that there were a number of case report in the literature showing the efficacy of TPE in managing severe pulmonary hemorrhage. TPE was readily available at that time at Teaching Hospital Karapiti because it was used in nephrology as well. And with this background, we decided to use TPE in patients with pulmonary hemorrhage. We initially treated 6 patients with leptospirosis, and we found it was successful. And we published this data in annual academic sessions of Ceylon College of Physicians. And with this encouraging result, we use it regularly thereafter. And we compared our pre-TPE and post-TPE results and published our work in 2019. The name of the paper was Sequel and Therapeutic Modalities of Leptospirosis Associated Pulmonary Hemorrhage, Hemorrhagic Syndrome, Sri Lankan Experience, which was published in BMC Infectious Diseases in 2019. The results of our study was, and we recruited 128 serologically confirmed cases of leptospirosis from June of 2015 to December 2017. The commonest complication we encountered was acute kidney injury, and which was followed by pulmonary hemorrhage. Out of the 128 patients, we had 80 patients who developed leptospirosis pulmonary hemorrhage. Percentage-wise, it was 62%. Highest death rate also reported among pulmonary hemorrhage patients with pulmonary hemorrhage as compared to non-pulmonary hemorrhage patient, which was 28. In summary, 80 patients whom had pulmonary hemorrhage had, out of the 80 patients, 59 were treated with therapeutic plasma exchange, and out of the 59, 42 survived. We achieved 71% of survival. And in the standard treatment arm, which includes steroids also, we had 19 patients, of whom only 2 survived, and there 17 died. The mortality was 89%. And other findings that in our other important findings of our study was, it was the largest cohort of pulmonary hemorrhage associated leptospirosis reported in Sri Lanka. It showed relatively higher percentage of leptospirosis associated pulmonary hemorrhage among clinically and serologically confirmed leptospirosis patients in southern Sri Lanka. We also observed that persistent hypotension, arterial hypoxia, and persistent tachycardia preceded the onset of pulmonary hemorrhage. TPE is a simple procedure where this is one of our patients whom we did TPE, and a simple machine we use. One nurse and one doctor can operate this and do the procedure. This was the X-ray he came with, and this was the result after 3 sessions of plasma. In summary, leptospirosis causes high morbidity and mortality in Sri Lanka. World over, clinical patterns of leptospirosis has changed in the recent past. Pulmonary hemorrhage causes significant mortality among leptospirosis patients. LPH is established clinical entity in Sri Lanka. Enough evidence is there to support that this clinical entity is becoming a major problem contributing to significant morbidity and mortality in our country. LPH is a result of immune-mediated lung injury. The therapeutic plasma exchange shown to be beneficial. Thank you.